Dear friends, today our class is inflammatory bowel disease and we will see what is inflammatory bowel disease. As you know that as the topic says inflammatory, that means it has to be a inflammatory in nature. What inflammatory? Either the inflammation may be because of any bacteria, any virus, any any pathology, or if we are not able to know the cause of inflammation, it may be idiopathic. And the most common cause of idiopathic inflammation of the bowel at present is autoimmune disease, where the body makes immune response against their own self. And here we will see that there we had got two major type of inflammatory bowel disease which we see commonly. One is Crohn's disease and the second is ulcerative colitis. Both had got lot of causes, but the major cause is inflammation or autoimmune pathology, and there are lot of difference in the clinical features of either disease. But if we see that regarding the etiology and diagnosis and treatment, it is almost similar in nature with some changes. So the the main differential feature is the clinical feature in either disease. Otherwise, we will have almost similar causes of either disease. Let's see. So, the inflammatory bowel disease is divided objectively into two types, that is ulcerative colitis and the Crohn's disease. If we see the incidence, it is very rare in our country because as we know that it is these autoimmune diseases are more common in developed country where the socio-economic condition of the people residing are high. They usually develop these type of autoimmune diseases. Hence, it is rare in our circumstances. And of course, it has also got a bimodal incidence. That means first incidence is in second to third decades, and if the patients alive after in 6 to 8 decade, the second peak may be seen at this age, where we have to rule out all other malignant causes of this disease, because we will see in the further lectures that they are prone for malignancies also. So, in first bimodal peaks, we will not have much about the malignant potential, but if the peak is occurring at the second half of the life, we have to think about the malignant etiology also. This is a disease which is more common in the smokers. The cause is not much more, but out of these, ulcerative colitis is more common in smoker compared to Crohn's disease. If we see the development of irritable bowel disease, just like in COPD, we had three major etiology, that is environmental triggers, luminal antigens, and the genetic susceptibility of the host. Normally, if all the three etiologies are present, then also only few of the percentage will develop irritable bowel disease. That means there are a lot of other reasons which we don't know, and it is a very less, almost in less than 10% of the people who are having all the three causative organism, then also the chances of developing irritable bowel disease is very low. So, what is first? What is Crohn's disease? It is a chronic inflammatory disorder that may involve any part of the alimentary tract from the mouth to anus, with propensity for distal small intestine and proximal large bowel. And as seen, it is more common in the developed countries compared to our place. This is the graphical interpretation of what we had talked right now. The Crohn's disease has got more prominent is the ileocecal region. First, second is the transverse colon, and third is the proctosigmoid junction, which is more commonly involved compared to other part of the GIT. The etiology and pathologies of irritable bowel syndrome. Here, this is the normal gut, and there is tolerance to the controlled inflammations in the normal persons like we. There is some environmental triggers like bacterial, viral, or other infectious causes, NSAID intakes, or others which we don't know. This will cause acute injury of the gastrointestinal tract. Normally, in a tolerant person, it will cause complete healing, but in a patient of irritable bowel syndrome or disease, this acute inflammation will cause chronic inflammation, because failure of repair or bacterial clearance is decreased in these type of patients, and hence they are more prone for irritable bowel disease. Their immune dysregulation is there in these type of patients, which may be because of either there is some deficiency of vitamin D or there is some leaky gut hypothesis. Similarly, there is environmental factors like gluten's in the diet, nutritional deficiency, virus, bacteria. These two causes changes in a susceptible genetic host, and of course, as we know that all genetic diseases or the diseases which has got a genetic basis are usually located on the HLA DR3, DR4, DQ regions of the HLA, and hence this disease is also more common in HLA, DR3, DQ and other genetic locations. So, in a nutshell, if the patient is having all the three types of progressive hits in the body, then there is chances that the patient would develop autoimmune diseases and will manifest as irritable bowel disease. As we have discussed, we ideally don't know the exact cause of the disease, but the putative things like some infective organisms like chlamydia, listeria monocytogenes, deficiency in the cell wall, especially in the pseudomonas, and mycobacterium paratuberculosis. These are few bacteria which are found more in patients of irritable bowel disease compared to the normal cohorts. Of course, HLA DR3, DR4 are positive. That means they are more common in monozygotic twins compared to other persons. They are very common in high socioeconomic status. That means if as a child or in the earlier stage, if they are not getting immune tolerance by these type of small hits in the body, they may be a reason why we are more resistant to these type of disease, because we don't get a very fine, polished, refreshed environment. We have to take water which is not very pure. We have to sit and be at a place which are not very hygienic. We usually takes fruits, vegetable and other uh, thing like pani puri or other things which probably are not so hygienic, and maybe these antigens may help in having less incidence of these type of gut autoimmune diseases in our populations. Of course, in smokers and in stress, these diseases are very much increased. The early findings are hepatitis ulcer. What are the hepatitis ulcer? They are superficial, less than 3 millimeter in size. It is usually because of lymphocyte aggregation in small intestine and colon, and of course they are sign of immune activation, as we know that it is type 4 hypersensitivity reaction. So the T cells are more positively seen in this type of ulcerations. Later on, it may transfer into non-caseating granulomas. They are usually found in any part of the body, GIT, but are more common over the skin, eye, liver, and it is very difficult to differentiate them from the sarcoid type of lesions because they also are non-caseating granulomas. In the later findings, the large stellate ulcers cobblestone appearance is seen when the linear and transverse ulcer interact, and network ulcers are found around the submucosa, and later on, because of strictures and impaired healing, the sinus tract may form. If not treated, this may change to fistula, which may get out of the body via skin, bladder, and vagina, and accordingly, we will have many different names of this fistulas. Inside, the healing may occur with fibrosis, and it may cause subacute and acute obstruction in the later part of the life. The strictures can occur in any segment of GI tract. They are silent initially but will cause obstruction, and the symptom of obstruction may occur according to the place of stricture development. As we have discussed that fistulas are very common in Crohn's disease because of impaired wound healing, and we know that these fistulas are lined by the epithelial cells, that is the epithelialization of the fistulous tracts occur, and hence it is very difficult for these fistula to heal by itself, and they will have chronic complaints of leaking of pus, drainage of pus from the body source to the outside. Here in this patient, because of anorectal ulcer, the patient developed this fistulous tract, and we know that the abscess or any cavity drains to the minimal resistance, that is here because of postural drainage outside near the perianal region, and it is very bothersome and difficult to get healed. Similarly, if the fistula is between the vagina and outside, the enterovaginal fistula is here. They are of course rare but may present as dyspareunia, or if it is connected with the rectum, feculent or fecal smell, they are often very painful. They are unlikely to develop without a prior hysterectomy. That means post LSCS, post surgery, these does not heal properly and cause the formation of fistulous tract. This is the enterocutaneous fistula. Here the tissue plane of least resistance is the scars over the abdomen, and hence this fistula tract come outside the body via the minimal resistance, and you see this is the laparoscopic places where the fistulas are made, and it's very difficult to get healed. If the bladder is connected to the vagina, the entrovesical fissulas occur. They typically present with dyspareunia and recurrent bladder infections. Sometimes they present as pneumonia or fecaluria also. Clinical features of the disease, they may present with diarrhea, that is increase in the stool frequency and decrease in the stool consistency. The altered fluid and electrolyte absorption and secretion decreases the stool consistency. The imbalance between the luminal concentration of bile salt to fat result in bile salt induced diarrhea also in these type of patients. The abdominal pain occur because the stretch receptors which are stimulated by the food passage through the stenotic bowel causing pain. The pain may be either visceral or the parietal because of abscess formation in the parietal cavities. As it is a chronic disease, the patient is having ill health since many times, and hence the patient will complain of weight loss and malabsorption of long standing durations. As this disease is very common in the upper and lower GI tract, the upper GI tract is the site for absorption of major carbohydrate, proteins, minerals, iron, calcium. So, in chronic patients, we will have the deficiency of major multivitamins, multiminerals, and of course, because of lot of interleukin secreted, the weight loss is precipitated by the symptom of decreased appetite. The cause of fever is the production of lot of cytokine and autoimmune factors from the body. The anemia is usually of chronic deficiency. The extraintestinal manifestation like clubbing, arthritis are also seen. Some very classical extraintestinal manifestation like pyoderma gangrenosum, erythema nodosum, episcleritis, uveitis, gallstones, sclerosing, angiitis, multiple uric acid stones, and venous thrombosis are also commonly seen in irritable bowel disease. If we go for the clinical laboratory features, as we know that it is an autoimmune disease, and all acute phase reactants, especially C reactive protein, ESR platelets are very high. Because of anemia, the hemoglobin is low. Fecal lactoferrin is very specific for this disease, and if the patient is a very chronic case, then the serum albumin would be very low, and of course any infective pathology is there, then the leukocytes count would be very high. To further confirm the disease, we have to go through the body either by lower GI, that is sigmoidoscopy, or through upper part, that is endoscopy. Here in either of the scopy, we put a video endoscope. This endoscope will see the classical features which are there in Crohn's or irritable bowel syndromes. As discussed, we can take small histopathological biopsy and we can confirm the disease. These both are also required for the surveillance of the disease progress. And of course, as we know that there is some chances of changing in the metaplasia, dysplasia and malignancy. So, this can be also used for confirming those dreaded complications. As we have emphasize this fecal lactoferrin is highly sensitive and specific marker for detecting intestinal inflammation. This is cobblestone street. We must have gone through this type of streets many times, and because of resemblance of this cobblestone, this is the endoscopic appearance of Crohn's disease, where this cobblestone is very characteristic, similar to this cobblestone street. These are the strictures associated with cobblestone appearance. This is the stricture, and this is the cobblestone appearance. A little bit about ulcerative colitis. Macroscopically, ulcerative colitis is the inflammation of the lower GI tract. It may be mild inflammation or a severe disease. Normally, we get a mild inflammatory disease and sometime interspersed with severe disease in the course of the progression of the disease. In mild inflammation, the mucosa is erythematous and fine granular surface that resemble the sandpaper appearance. This is the sandpaper appearance in mild inflammation. And in the severe disease, the mucosa is hemorrhagic, edematous and ulcerated, and pseudopolyps are present. And after many years of disease, the mucosa is usually atrophic, featureless, and the entire colon becomes narrowed and shortened. Usually here the process is limited to the mucosa and superficial submucosa compared with the Crohn's disease, where the disease is pan, GI, that means all the part of the gut are involved from the epithelium to the muscular wall. In ulcerative colitis, two major histological features suggest chronicity and help distinguish it from the infectious cause of colitis. That is, in infectious colitis, the crypt architecture of the colon is distorted. Crypts may be bifid and reduced in number, often with a gap between the crypt's basis and the muscularis mucosa. In ulcerative colitis, the basal plasma cell and multiple basal lymphoid cells aggregates are usually prominent. If we see clinically, these are the symptoms which are usually present when the patient is having acute inflammation, and these are the symptoms which are present when the patient is asymptomatic also. If we go from head to toe, during acute attacks of ulcerative colitis, the patient will have conjunctivitis, iritis, episcleritis, epithelial ulceration in the mouth. The patient would have fatty liver, liver abscess, portal pyemia, mesenteric or portal vein thrombosis, multiple venous thrombosis, arthalgias of the large joint, erythema nodosum, and pyoderma gangrenosum. These are the features which are usually seen in a patient who is in acute inflammatory ulcerative colitis. But autoimmune hepatitis, sclerosing cholangitis, gallstone, amyloidosis, sarcoiditis, metabolic bone disease are present when the patient is in the remission also, and this should not be confused with the acute attack of ulcerative colitis. The major symptoms of ulcerative colitis are diarrhea, rectal bleeding, tenesmus, passage of mucus, and crampy abdominal pain. Physical signs are very rare, except the signs of proctitis, that is tender anal canal and blood on the rectal examination. Tenderness to palpation directly over the colon is also a particular sign in ulcerative colitis. Here also, fresh blood or blood-stained mucus, either mixed with stool or streaks into surface of normal or hard stool, is classical feature. If we classify ulcerative colitis with the disease presentation, it may be classified into mild, moderate, and severe. In mild, the bowel movement are less than 4 per day. In severe, it is more than 6 per day. Blood is very severe in severe. Fever is usually present in severe presentation. Tachycardia is there in severe presentation. ESR is more than 30 millimeter in severe presentation. And in the endoscopic appearance, erythema, decreased vascular pattern, and fine granularity is seen in the mild case, and spontaneous bleeding or ulceration are seen in the severe case of ulcerative colitis. As in the Crohn's disease, the laboratory features are similar, that is raised acute phase reactant, that is CRP, platelet, ESR, hemoglobin is less, fecal lactoferrin is the investigation of choice. In chronic disease, the albumin would be very low, and infective causes the leukocytosis may be there. Similarly, sigmoidoscopy endoscopy has to be done to confirm the disease and get the sample for histopathology. Barium enema, this is the earliest radiological changes that is fine mucosal granularity is seen, superficial ulcers are seen, deep ulcerations, that is collar button ulcers, haustral folds become edematous and thickened, loss of haustoration later in long-standing disease, and colon becomes shortened and narrowed, and polyps may be present. This is the barium examination of a typical case of ulcerative colitis. Here the loss of haustorations are there, and the transverse colon is dilated to more than 6 centimeter in the center. This is the distended loop of the small bowel. This is the barium appearance of the transverse colon, lower proctosigmoid junction, and the ascending colon. See, loss of haustoration is there, and it denotes a long standing ulcerative colitis. This is colonoscopic appearance. The severe inflammation with erythema, friability, and exudates are seen in the colonoscopy. The complications are usually hemorrhage, toxic megacolon, perforation, and very rarely strictures. Hemorrhage is when the patient requires more than 6 to 8 units of blood in 24 hours. That means the patient has to go for major surgery, that is hemicolectomy. Otherwise, it is very difficult to save the patients. Similarly, toxic megacolon is defined as transverse or right colon with a diameter of more than 6 centimeter with loss of haustoration in patient with severe attacks of ulcerative colitis. This is toxic megacolon. The size is more than 6 centimeter. So the complication of ulcerative colitis is toxic megacolon. Here, acute colonic dilatation with transverse colon diameter more than 6 centimeter. It is seen when the inflammation occurs beyond mucosa. It occurs in less than 5% of the cases. Hypokalemia may be because of use of anti-motility drugs, which may precipitate toxic megacolon. The sign and symptoms include fever, tachycardia, abdominal pain, distension, decreased bowel sound, and tenderness on local examination. Long-standing patient may also develop stricture. It usually occurs 2 to 3 centimeter distal to the splenic plexus. Hypertrophy of muscularis mucosa is there rather than fibrosis, and patient can have alternative diarrhea and constipation as a clinical presentation. Dysplasia and colorectal malignancy. The risk factor include positive family history, presence of pseudo polyps, presence of backwash ileitis, Dysplasia can be classified into high and low grade dysplasia on histologically. In high grade, branching of glands in cribriform plate is seen. Endoscopically, they can be divided into invisible and visible dysplasia. The high grade dysplasia predict malignancy, and hence we should take the endoscopic biopsy every 2 to 3 years when the disease is beyond 8 to 10 years of duration. This is the difference between the ulcerative colitis and Crohn's disease. The Crohn's disease, as we have discussed, is transmural, and this is usually mucosal. The pattern of disease is contagious in ulcerative colitis, and there are a lot of skip lesions in Crohn's disease. In ulcerative colitis, the location is usually colorectal, and it is pain GI, that is from mouth to anus. Rectal involvement is very less in Crohn's disease compared to ulcerative colitis. Similarly, ileal disease is rare in ulcerative colitis. Fistulas and perineal disease are very common in Crohn's disease. Granulomas are very common in Crohn's disease. Bleeding is common in ulcerative colitis. Malnutrition is more common in Crohn's disease. Cancers are more common in ulcerative colitis, and tobacco is protective in ulcerative colitis and harmful in Crohn's disease. This was a small talk over the irritable bowel disease, and if you had any queries, you can ask me over the WhatsApp group, or you can call me. I am ready to help you for this chapter. Thanking you a lot.